Next, I would like to introduce Dr. Saurabh, who is joining us all the way from Illinois. And Dr. SAURABH BANSAL is an associate professor of clinical medicine, the Department of Internal Medicine at the University of Illinois. He's been on the teaching faculty for the past 10 years, frequently works with medical students and residents, and very involved in the simulation curriculum. And Dr. Bansal has been working on the front lines of the COVID pandemic since it arrived in the United States. We'd like to thank him for that and thank him very kindly for joining us this morning to share his talk with us today. So Dr. Bansal, please join us and we will pass the microphone to you. Thank you.
I think Dr. Divya wants to say something about Dr. Bansal. If Dr. Divya is around, she wants to say a couple of words about Dr. Bansal, I think. Dr. Divya, are you there with us?
Hello.
Yeah, Dr. Divya, go ahead.
Hello. First of all, Dr. Vijay Mohan, thank you so much. With this endeavor of yours, you proved that distance doesn't matter if you have a passion for medicine, and distance learning is a way to go. So we are all proud of you. Thank you so much.
Thank you.
Dr. Bansal, I've had a chance to work with Dr. Bansal, and I just want to say that he's another passionate doctor I've met in the recent times in lines of Dr. Vijay Mohan. I've done some research work with him, and I know that he's a wonderful teacher and a very popular teacher as well. So welcome, Dr. Bansal. Glad to meet you today.
Okay, well, thank you everyone for such a great introduction. Thank you, Alex. It was wonderful. Thank you, Dr. Pramod, and many thanks to Dr. Vijay Mohan for organizing this. As you can see, we are sitting very far apart, but technology has brought us a lot closer. So I am from a kind of suburban town in Peoria, Illinois. So it's a little bit far away from Chicago. And it's called Midwestern. It's in the Midwest region of the United States. So I'm going to share my screen here quickly with you and then start my presentation. Okay. Can everybody see my screen here?
Yes.
Okay. Okay, thank you. Okay. So I think some of these things may have been covered by previous presenters from the panel discussions, but and some of these things that I'm going to talk about, you might find you may not have heard about, but these are, I think it's an important topic or important to know from the aspects of knowing how this disease presents. Because the more you know, the better it is. So what I was planning to talk about is atypical or inconsistent presentations of COVID-19. So, because one thing you do sort of want to understand here is that if you miss one case and you admit them to the hospital and somehow you don't suspect them to be having COVID, and suddenly you do not put them in isolation, or at least here it can happen, then you have 15, 20 doctors and nurses who would see the patient without appropriately gowned up or appropriately using protective equipment. And then they all can get exposed and then can get infected, and then they can go home and infect their family members, and those family members can go expose others. So really breaking the chain down of this infection is key to prevent the spread. And knowing how this disease presents, even typically or atypically, is equally important. So I think most common presentations you all, most of you are aware of. CDC, which is Centers of Disease Control in the United States, studied about 37,000 patients. And cough and fever obviously is the most common presentation, we all know. Even though it says 50%, 43%, this is at the time of presentation, but in the middle or the end of the illness, almost 80 to 90% people would have had fever. The other interesting thing that I noticed here was a sore throat is a lot less common, like 20%, and rhinorrhea or runny nose doesn't make the list, which I think is important because most of us, when we think about viral illnesses, we immediately think about runny nose and sore throat. So, which is not as common. And the reason that becomes even more relevant now as we run into fall and winter season, pretty much most parts of the world, we're going to see spring of other viruses. We're going to see other viruses like influenza. We're going to see adenoviruses coming into play. And most of those viruses have a different symptomatology pattern. So knowing that not everything is going to be COVID, we're going to be dealing with more than one viruses as we enter into the new weather season. So I think the most atypical presentation or inconsistent presentation is the asymptomatic infection. So the study has been done by many authors. Most people think it's about 30 to 40%. Now, there are studies and authors who believe up to 50% of the infection can be asymptomatic. But most people believe it's about 40% range. It also introduces a concept of infection versus disease. That's why we are hearing two words. Many of you may already know. SARS-CoV-2 is a virus which causes infection, but COVID-19 is a disease. So you can be infected, but you may not have the symptoms. And if you don't have the symptoms, you don't have the COVID-19, which is a disease. So you still can be infected and you can have the virus multiplying in your nasal passages or your upper respiratory tract, and you can still spread it, but you may not have the disease. The other thing is a longitudinal follow-up was lacking in most of these studies. So we don't know very clearly how many of these asymptomatic people end up getting infection. There was a small study done in King County, Washington, very early on, I think in March and April time period, where they screened everybody when the outbreak was happening in this nursing home. They screened every resident for COVID-19, and what they found was that about 56% of the people tested positive, but they were asymptomatic. But another good thing they did was they followed up these patients and then tested them again and checked how many developed symptoms. So almost 80 to 90% of the people developed symptoms by the day 7. And that's what introduces a concept of asymptomatic versus pre-symptomatic. So you may have both of those words. What that means really is that people who are asymptomatic in the beginning, when you test them and they're positive, do they end up developing symptoms? And if they do, then technically one might want to call them pre-symptomatic rather than asymptomatic. Having said that, asymptomatic infection, again, is not as asymptomatic as you might think. In one study by authors in China, again, this was very early on in the disease, in the pandemic, where they studied about 55 patients, a very small number, who were found out through contact tracing, who were asymptomatic, tested positive. And when they did CT scans on these people, they found about 67%, which is 2/3, had some kind of findings on their lung imaging, like ground glass opacities or consolidation. So what they concluded was that there's a fair amount of people who still have lung findings, but they may be compensating well enough that they do not develop symptoms to show off. And they also saw that there were 2 patients who developed hypoxia, but they all recovered very well. So that's a good sign. I do think there may have been a selection bias. I don't think the number, if you take general population, everybody who's asymptomatic, and if we scan them, I don't think we're going to have 2/3 people having CT scan findings, but definitely the asymptomatic patients still have evidence of disease if we image them. The other the uncommon or unusual thing with this infection is anosmia, hyposmia, or dysgeusia, which is loss of taste, loss of smell. It is a distinguishing feature. I would say it has been seen with other viral illnesses, but not so commonly. But it's fairly common by the end of this COVID-19 illness. In this one study, they studied about a little more than 2,000 patients who had COVID-19. Most of them were in the ambulatory world, which is outpatient or OPD setting. They were not admitted. almost up to 87% reported loss of smell or loss of taste. But if you see the number of people who present, it's about 10% or less. So it's not completely zero. So maybe up to 10% of the patient may present just with loss of taste or loss of smell. So knowing that is very important, because if somebody presents, especially during this pandemic period, it's important to test these people early on, because that might be a symptom of COVID-19. The other thing that is also seen is most of the people on an average develop loss of taste or loss of smell on about day 4. So it's not a very common symptom on day 1, but it is. But many will develop symptoms on 4th or 5th day of the illness. The reason people think theory is that the ACE2 receptor, which is angiotensin converting enzyme 2 receptor, which has gotten a lot of good reputation and bad reputation because of COVID-19, used to be a good receptor because of the ACE inhibitors. So that is expressed in the olfactory epithelium, and that is believed, at least for now, to believe the theory that how the virus enters. One thing that they noticed on autopsy studies was that it does not affect the neurons, it does affect the olfactory cells. And which is perhaps why most of the people, when they did follow-up studies on these patients, 90% recovered within 4 weeks. So 90% of the patient will report complete resolution of these symptoms by the end of 4 weeks, which is a good thing. Many societies, ENT societies in UK and America, have released statements that if the person does not have reasons to have loss of smell, and if they presented with that, we should go ahead and test them for COVID-19. This is my sort of favorite one, gastrointestinal symptoms, because I think that could be a great sort of a great mimic or can fool many people. So the most common reported GI symptoms with COVID-19 is nausea, vomiting, diarrhea. So from my own personal I've at least had 2 people in my personal circle who blamed it on food poisoning. They felt that they had eaten something outside, or they felt there was something they did which caused them to have these GI symptoms, and they didn't believe it was COVID-19. But there's about one study I pointed out here by Luo, felt that almost up to 16% patients may present only with GI symptoms without having any respiratory symptoms. So knowing if your friend, family member, or even if your patient comes and tells you that I ate outside yesterday and now I'm having nausea, vomiting, diarrhea, it's not really from the food. It's perhaps a few days ago when they got together in a big number and 10 or 15 people ate together. Perhaps that's how they got exposed to the COVID virus, and that's how they got this illness. So that's very important to know. And again, the same receptor ACE2 is believed to be why how the virus enters the GI system and how it causes illnesses. It has been found in multiple GI sites. One thing I do want to point out, which I think I noticed, was that many authors also include anorexia, which is loss of appetite, as GI symptom. And then they conclude that more than 50% of the people have GI symptoms in COVID-19. I think loss of appetite is kind of a symptom that happens with many illnesses, so I don't consider that particularly as GI specific. So I don't want to make the conclusion that more than half the people have GI symptoms. It's not as common, but it is there, and it should be kept in mind. Another thing with GI symptoms that should be kept in mind is, so the authors here did a meta-analysis of almost 30 studies. And what they found was, when they pooled all this data together, they found about 12% of these patients had GI symptoms, not necessarily at the time of presentation, but throughout their illness. But another interesting thing that they observed was about 40% of these patients were shedding virus in the fecal matter. So what that does is that raised the alarm bells, and everybody was made aware of that people who are handling, especially in the hospital, who are handling garbage or fecal material should also be adequately protected buy PPE so that transmission doesn't happen. Another thing that's been commonly seen is dermatological manifestations in COVID-19. So these are some of the most common ones that you would see. The picture on your right, you can see it's a morbilliform rash, which is the most common one that you'll see with COVID-19. It's really a reddish maculopapular type of rash. If you look at the picture, you would feel like this is pruritic. But interestingly enough, most authors report that most patients, the rash is non-pruritic. So something to keep in mind when you see a rash which is non-pruritic like this, think about COVID-19. But you can have urticaria, vesicular, which is herpes type eruptions, or purpura. Another one, the second most common, is pernio-like acral lesions, and these are the ones if you if you're staying in touch in media, that is the one that got at least a lot of attention here in the United States. It's called chilblains, which is a local word, and pernio is kind of a medical term, and then it was dubbed as COVID toes in the media. So pernio is not a new condition. We've known that it exists. As you can see in the picture on your right, you see this reddish kind of painful lesions on your toes. It almost makes you think sometimes it could be gout, but the thing to see is that it doesn't affect the big toe as much, which the gout will, but the little toes more than the big toes. Commonly, it happens with cold weather. Mostly it is primary without an unknown cause, but secondarily it can happen from autoimmune diseases. And this was seen fairly commonly with COVID-19 infection without the exposure of cold. So we know most of the time, in the past few months, most of the countries were having weather of summer, but patients were coming, reporting having these lesions on their toes. The good thing is most people who've had this perniosis had milder disease. Almost, some authors report up to 90%. It is something that happens 2 to 4 weeks after COVID-19 infection. So generally speaking, it doesn't start at the onset of the illness, which is why it has been reported or suggested that if you have somebody who's had these lesions for 2 to 4 weeks and comes to see you, think about they may have missed a milder infection of COVID-19. And if they did, then perhaps check them for IgG. And if they do have IgG level, you can ask them to donate plasma for plasma therapy. And some people have tried corticosteroids, but most of these lesions go away by itself. Interestingly enough, another case series by author Herman and colleagues thought that it was related to the lifestyle changes, and certainly many people will agree that lifestyle did change for a lot of us. They reported that these lesions happen because most of these people are walking barefoot in unheated homes. We're inactive and we're spending more time in sedentary positions. So certainly that is true that many people are spending a whole lot more time in their homes than they used to previously. And when they biopsy them, you see vasculitis or vessel endothelial damage. So the other theory is that people think that it could be that these COVID toes happen because of endothelial damage. Neurological manifestations, again, fairly common, can be seen up to 1/3 of the patients. What does seem to be the case is you can have all the way from headache to altered consciousness to dizziness to encephalopathy, agitation, confusion, delirium. You can have all of those, but most of these symptoms have been seen in the middle of their illness. So most of these are thought to be related because they are ill and not necessarily a direct invasion by the virus of neural cells. Some of the authors did do biopsy on the studies where they published. They autopsied and brain biopsied 18 patients who died of COVID-19 and looked at looked at the specimens, and most of them showed hypoxemic ischemic changes, which is what is seen commonly. A lot of these patients are hypoxemic, they're on ventilator, and that is what they're seeing. They did not see a whole lot of encephalitis or viral invasion
Excuse me,
of the
Dr.
neurocells.
Saurabh. Sir,
Yes.
the time limit has been exceeded, sir. Could you please finish your presentation quickly, sir? I'm sorry to
Absolutely.
cut you.
Okay, so I have just yeah, no problem. Thank you for reminding me that. I just have a couple more slides and I'm gonna finish real quickly here. So, so one more thing that was seen was myasthenia gravis. 3 cases were reported by an author, thought to be autoimmune, but they were tested positive for COVID-19. Another thing that was seen was Guillain-Barré syndrome, very low number. One study out of Italy reported 5 patients out of 1,200 who were admitted, and they had features consistent with Guillain-Barré syndrome, and they happened at the time of the illness. Acute ischemic stroke has been reported. This one study reported 5 patients who were younger than 50 years and had large vessel stroke. And 2 out of these 5 patients actually did not have any COVID symptoms at the time of presentation. And perhaps it is related to the hypercoagulable state, although that theory is not completely proven. Whether these strokes were because of hypercoagulable state, and there's other neurological manifestations that you can see, such as encephalitis. Case reports are out there, but very, very, very uncommon. They're not very common. Another thing I want to quickly point out here is multisystem inflammatory syndrome, also known as MISC. And these happen more commonly in children. And one study in New York reported 70% of the patients were under 12. And the not so good thing was 80% of these people were admitted to intensive care unit. And the presentation is very, it's atypical, but matches many features of Kawasaki disease. It's my last slide here. So one thing to also notice and remember is our elderly folks, are people who are over age 70 and who have neurocognitive impairment or have dementia. They can present in many different ways. So they can present with fall, they can present with sudden decline in general health, such as failure to thrive, or they can even have no fever, hypothermia. So if an elderly presents with weird, unusual symptoms, still think about COVID-19. So that was my last slide. I thank you very much for listening to all of you who are all out there, and appreciate you coming and attending this meeting, and thank you for allowing me to talk here.
Dr. Bansal, thank you for the excellent talk. It was great to go over all of the interesting, atypical manifestations of COVID, and I'll keep my eyes out for those on the wards. Thank you. Excellent talk.
Dr. Bansal, can you stick on for some more time till one more talk? Because we want you to be around with the panel discussion. Probably we will have a couple of questions for you if you're free, Dr. Bansal.
I will try. I apologize, but unfortunately, I do have to round today. I'm actually working. So so I apologize. I would really like to hang out here more and wish I could attend a little bit more.
Can I ask a quick question? Because you're in a hurry to go. Thank you very much.
Yes, I can take a few questions.
Enlightening talk. Really, it was a wonderful lecture. We have many things, but I have a quick question for you. Since the virus, the main port of entry is nose, why not everyone will have smell defects, the anosmia? Why is it only common in present in only few people? Because the viruses, the port of entry is directly through the nose, and ACE2 receptors are present there also. But why not everyone will have?
I think that's a great question. I think, and that's what we're seeing here with this viral illness, that not all patients are presenting with very typical symptoms, and we're seeing all these atypical presentations.